So, good evening, guys and girls. I am Dr. Umkar Sangita Diliprasonone, and today I welcome you all back again to the session of Sparks. Today's discussion is going to be about a very high yielding subject, that is orthopedics. I hope all of you are. All of you consider this fact that orthopedics, though it is a shorter subject, but it is very high yielding because it covers most of the questions from anatomy, radiology, and all the other allied subjects. Okay, so I hope you have gone through your notes before listening to this session. And now coming to the actual discussion of orthopedics, I know that most of the AFMG students have attempted their orthopedics test yesterday. I hope most of you have did that. And apart from this, all the other students have received the same test on the WhatsApp group, and those who did not receive it, no worries, we'll go over here together. So I would like to throw some light first that in this session, the orthopedics test and discussion series would be divided into two parts. The first session will be discussing 20 questions, and the next session will be discussing 20 questions in the subsequent session, right? So without any further delay, I hope we will start with the session. We'll begin the session. Just a note before that, guys, please try to answer most of the questions in the chat box, because when you answer, the sessions becomes more interactive and it is going to help you out, right? So please remember this and try to be more interactive in the session. So let's begin this session without any further delay. Now the first question, guys, that we have today is, who is considered the father of orthopedics? And I feel this is the most basic question that you guys need to know. And as we all know that mostly regarding fathers, like these are the one-liners about which questions were asked previously, and now also they can ask at any point of time. Therefore it's better to know like these 4 to 5 points. So any answers, and the options are A, Dr. Robert Jones; B, Dr. Nicholas Andrey; C, Dr. H.O. Thomas; D, Dr. John Chanley. Any answers? So just type your answers in your chat box. So yeah, let's start our discussion first of all. Now most of, like, I would wait for this answer, guys. I hope like most of you know the answer for this question, so at least try to answer this question, so then we can just move forward with the discussion. So now let's begin, guys. First of all, okay, Dr. Robert Jones is your answer. Okay, guys, now let's begin with the discussion. So here the answer is option B, Dr. Nicholas Andrey. So please remember, guys, Dr. Nicholas Andrey is considered the father of orthopedics. Okay, though some books tend to differ it. So please remember, Dr. Nicholas Andrey is considered the father of orthopedics, as he coined the term orthopedics itself. Okay, he coined the term orthopedics. So please remember, who coined the term orthopedics? It was Dr. Nicholas Andrey. Okay, and therefore he is known as the father of orthopedics. But more work actually in orthopedics was done by Dr. Hugh Owen Thomas, that is Dr. H.O. Thomas. Okay, so please remember, therefore Dr. H.O. Thomas, as he cannot be regarded as father of orthopedics now, therefore he was regarded as father of British orthopedics. So please remember, Dr. H.O. Thomas is father of British orthopedics. And Dr. Thomas' contribution is very much important. What did Dr. Thomas give to us in orthopedics? So please remember, Dr. Thomas gave us the Thomas splint. Okay, and this Thomas splint, as you all might be aware of the fact that this Thomas splint is usually used to immobilize for immobilization in cases of lower limb trauma or lower limb fractures. In most of the lower limb trauma, whenever you need to transport the patient, the primary splint that is given to the patient is this Thomas splint. Second, he also gave your cervical collars. Okay, and the third thing he gave was your Thomas test. Okay, important one. He also gave your Thomas test, important one. Okay, Thomas test is for the fixed flexion deformity at the hip joint, right? So please remember, these are the important points. Dr. Robert Jones, as you know, so please remember, Dr. Robert Jones is actually the father of modern orthopedics. Okay, Dr. Robert Jones is father of modern orthopedics, important thing. And Dr. John Chanley is who? So please remember, Dr. John Chanley is considered the father of arthroplasty. Okay, Dr. John Chanley is considered the father of arthroplasty. Remember this. Okay, whereas father of traumatology is whom? So please remember, father of traumatology is Dr. Bohler. Okay, father of traumatology is Dr. Bohler. whereas father of sports medicine is Dr. Gallen. These are two not very much important ones, but at least those four options you need to remember at any case. Okay, now moving further guys to our next question that states a person met with a road traffic accident and presented to the emergency with left ankle swelling and pain. The radiograph is shown below. Which is the likely fracture seen? Options are A. Bumper fracture, B. Cotton's fracture, C. Nightstick fracture, D. Pott's fracture. And as we all know, fracture eponyms have always been a very important part of the examinations, of any of the examinations. So please remember guys, at least the important fracture eponyms you need to remember. Okay, so these are all your eponyms. So what you can see over here in this X-ray, okay, what you can see over here at the ankle joint, please focus. This is your distal part of your fibula. Okay, distal part of fibula, that is your malleolus. Okay, so please remember what we can see. We can see the medial as well as the lateral malleolus, both are fractured. Therefore this is a condition known as bimalleolar fracture. This is what? A condition known as bimalleolar fracture. And what is the eponym used for bimalleolar fracture? I feel you are getting confused. Please remember what is the condition used for bimalleolar fracture. So please remember guys, this is a pot. Okay, I tend to remember it like this. This is a pot and this is a cotton. Okay, this is how a cotton looks like. So pot has two circular surfaces, therefore it is a bimalleolar fracture, whereas cotton has three circular surfaces, therefore it is a trimalleolar fracture. This way I feel it is easier for me to remember these things. You can go according to you. Pot has two circular surfaces, therefore bimalleolar. Cotton has three circular surfaces, therefore trimalleolar. So which is the correct answer now? Please tell in the chat box. Therefore the correct answer to the question number 2 would be option D, that is Pott's fracture. Now let's move on to these few fracture eponyms that you need to remember. This you can find in our FMG snaps that you might have. If you don't have these FMG snaps, please find it in the Telegram group of AFMG for FMGE. Okay, you can find this. So in this FMG snaps, I have actually included some eponyms. So please remember this. What is this? The first fracture you can see over here. Okay, this is your radius bone, this is your ulnar bone. So you can see fracture of the ulnar shaft. So please remember, fracture of ulnar shaft is also known as the nightstick fracture. Fracture of ulnar shaft is also known as your nightstick fracture. So what is a green stick fracture then? So please remember, green stick fracture is usually a fracture seen in children, okay, when the one part of the cortex is fractured whereas the other part of the cortex remains intact. Okay, it is usually seen in children. Okay, green stick, whereas nightstick fracture is the ulnar shaft fracture. The second image shows you what? It shows you fracture of the radial styloid process. At the distal end of the radius, when it articulates with the wrist joint, what we can see, we have the styloid process of the radius. So here we can see the fracture line at the styloid process of the radius. So fracture of the styloid process of the radius is known as what? It is known as your Schoffer's fracture. It is known as your Schoffer's fracture. Important. Next one, and third image shows you what? It shows you a side swipe injury pattern or a baby car fracture. So when a child is sitting in a car with his elbow resting on the window, what happens if a vehicle comes from behind and hits his elbow? So what can happen? This type of injury can happen. Okay, so this type of injury is known as side swipe injury or baby car fracture. In that, what are the fractures seen? So please remember, it is a compound fracture where we can see distal humerus fracture mostly at the supracondylar region. Then we can see a proximal ulnar fracture along with a radius fracture. Okay, so please remember, we can see a radial fracture, a proximal ulnar fracture and a distal humerus fracture. Then the next one over here, what is this? This is your bumpers fracture. So bumpers, by the name itself you can know, when a pedestrian is walking by road and a car comes and hits him. Okay, so if a person is walking by road and a car comes and hits him, okay, so mostly the bumper of the car would impact, and this bumper usually hits where? It usually hits at the lateral aspect of your leg. It usually hits at the lateral aspect of your leg, just near your knee. Okay, and that part where it hits, it causes what? It causes a lateral condylar fracture of the tibia. Tibia has two condyles at the upper surface. As we all know, at the upper end of tibia we have the medial condyle and the lateral condyle. So usually the lateral condyle of the tibia is fractured, and at times what can happen, the fibular neck can also get fractured due to the lateral impact of the car, right? So this is known as your bumpers fracture. And usually if the fibular neck gets fractured, what we have around the fibular neck, we have the common peroneal nerve which wounds around the fibular neck. So if the fibular neck gets fractured, then there can be injury to the common peroneal nerve, leading to a foot drop deformity, right? Now moving on to the next fracture that we have already seen in our question, we can see here both of the malleoli, that is your lateral as well as the medial malleolar fracture. Therefore it is known as a bimalleolar fracture, known as your Pott's fracture. The next one over here you can see, now this one, okay, this is what lateral, medial as well as the posterior malleoli, all of the three are fractured, okay. It is a trimalleolar fracture, and it is known as what, it is known as your Cotton's fracture. Next one is your Pilon's fracture. What do we mean by a Pilon fracture? Pilon is an intra-articular tibial fracture. So at the distal end of the tibia, okay, intra-articular fracture agar hota hai, this one, okay, intra-articular fracture of tibia is known as a Pilon's fracture at the distal end. Please remember this. Next is your aviator's fracture. What do we mean by aviator's fracture? Aviator's fracture is the fracture at the neck of talus, okay. So please remember, one of the tarsal bone is talus. So whenever there is a fracture at the neck of the talus, that is known as your aviator's fracture. One important point to be remembered about aviator's fracture is that aviator's fracture can lead to a complication known as AVN, that is your avascular necrosis, because the blood supply to the body of the talus would be cut off, and that can lead to AVN of talus, okay, avascular necrosis. It is one of the common sites where avascular necrosis occurs, okay, important thing. Next one is your this, which is this fracture. So please remember what we can see over here. Here we can see the fracture line from throughout the anteroposterior diameter of the vertebra, okay. The fracture line runs throughout the anteroposterior diameter of the vertebra, and this is what, this is known as your chance fracture or seat belt fracture. When during while driving a car, a driver applies sudden brake, and when he hyperflexes on the seat belt, that can cause this fracture known as chance fracture or seat belt fracture. Next one over here you can see fracture at the base of the fifth metatarsal, okay. This is your little finger. So fracture at the base of the fifth metatarsal is known as what? It is known as your Jones fracture. And if the fracture is over here at the tip of the fifth metatarsal, then that would be known as your pseudo-Jones fracture, also known as dancer's fracture, okay, important. Next one is what? Next one is the fracture at the C1 arc, okay. This is your C1 vertebra, that is your first cervical vertebra, also known as atlas. So if the arc of the atlas gets fractured, this is known as your Jefferson's fracture, okay. Fracture at the C1 arc is known as your Jefferson's fracture. Next is what? Next one, okay. Next one is your fracture of spinous process of your 7th cervical vertebra. Fracture of spinous process of the 7th cervical vertebra is known as what? It is known as your Clay-Shawler's fracture. How do I remember this? C goes for your cervical vertebra, S goes for your 7, okay. So please remember this. Clay-Shawler's fracture is fracture at the spinous process of your 7th cervical vertebra. Next one is your this, and this has been asked earlier also. Please remember guys, this is your hangman's fracture. What is this? This is your hangman's fracture. So what are the two important things that you can see in a hangman's fracture? Hangman's fracture is the most common fracture seen in cases of judicial hanging. Question from forensic medicine. Please remember, okay, it is the fracture which is seen in cases of hanging. And in hangman's fracture, what we can see, first of all, there is fracture of the spinous process of the 2nd cervical vertebra, that is axis, okay. There is fracture of the spinous process of axis vertebra, along with translation of C2 over C3, okay. C2 moves ahead, there is translation of C2 over C3. These are the two components of your hangman's fracture, usually seen in cases of judicial hanging. The last fracture that you can see over here is your burst fracture, okay. Burst fracture is again a vertebral body fracture, okay, almost a crushed fracture of the vertebral body, and this is known as your burst fracture, right. Moving further to our next one, question number 3 guys now, okay. What is the question? A 43-year-old male presents to the ortho OPD with complaints of backache. On history taking, patient agrees of significant weight loss over last 6 months, anorexia and evening rising fever. MRI spine ordered is given below. which is the earliest neurological deficit. So first of all, what do we need to know? First of all, we need to know the provisional diagnosis. कि provisional diagnosis है क्या, फिर तो हम पता लगाएंगे कि earliest neurological deficit होगा क्या इसमें, right? So anybody, what is the provisional diagnosis of this condition? What you can see over here, this is your MRI spine given, okay, and what you can see, just between the vertebral bodies you can see the disc is affected, right? The disc space is reduced and the disc is affected. There is a discal destruction we can see, okay, destruction of the intervertebral disc can be seen over here, right? What is the probable condition? What do you think? So please remember guys, what is there? We can see backache, as there is spinal involvement definitely, but the history is very much important. What we can see in the history, there is significant weight loss over last 6 months. Significant weight loss is more than 10% of weight loss over last 6 months, okay, that is considered significant. Next is anorexia, and third is your evening rising fever, okay, evening rising fever. These all conditions mostly point towards the diagnosis of tuberculosis, okay. So please remember, most of these findings point towards the diagnosis of tuberculosis. Yes, very good Gaurav. So this is your tuberculosis of spine. So now tell me, which is the earliest neurological deficit seen in cases of tuberculosis of spine, TB spine mein? Which is the earliest neurological deficit seen? Either it is motor component which is gone first, sensory, bowel or bladder movement. You say bladder is gone first, okay. So let's discuss few points about your Pott spine guys. What do we mean by Pott spine? So as we all know, Pott spine is nothing but the tuberculosis of spine, right? Pott spine is your tuberculosis of spine. As we all know, tuberculosis, most common organ affected is your lungs, followed by lymph nodes, followed by GIT, and then fourth are your bones and joints, okay. Fourth are your bones and joints. In bones and joints, which is the most common bone affected? So please remember, it is your spine which is most commonly affected, okay. The most common affected bone in cases of tuberculosis is your spine, important one. Which area of spine is affected? Which is the most common area affected? Either it is cervical, dorsal, lumbar, sacral or coccygeal. So please remember, in cases of Pott spine, dorsal spine is the most commonly affected area. That is your thoracic spine, you can say, okay. So dorsal or thoracic spine is the most common area affected. So which is the most common site affected? So please tell me. And dorsal spine mostly at the D12 or T12 you can say, okay, at T12 site it is the most common area affected. Which is the most common site? So please remember, paradiscal site is the most common one, okay. Paradiscal matlab kya? Disc ke upar aur niche, okay. The intervertebral disc is the most common site which is affected. So paradiscal is the most common site affected. What is the earliest or the most common symptom? Easy, right? It is tuberculosis of spine. और spine का patient कैसे present करेगा usually with back pain. So please remember, the earliest symptom or the most common symptom, both of them are your back pain. What would be late presentation? Late presentation would be neurological deficit. Definitely in the early stages it would not affect your, it would not involve your nerves, right? So neurological deficit would be seen late in course of the disease. So neurological deficit. Now which is the sequence or the order in which the neurological deficit occurs? Which is the first component to be lost and which is the last one? So please remember guys, motor component is the first one to be lost, followed by your sensory component and followed by your bladder or bowel. So please remember guys, bladder or bowel is the last component to be affected. It is not the first one, okay. First one to be affected is your motor component, okay. And what would be the first sign then? So please remember, if motor component is affected, there would be exaggerated reflexes, okay. Brisk or exaggerated reflexes are seen along with spastic paralysis. Along with spastic paralysis, that is rigidity would be seen, right? So please remember this. Now for diagnosis, what we do, the first line investigation performed would be your X-ray spine, right? X-ray dorsal spine usually we perform. And what is the first sign that can be seen on an X-ray? So please remember, as I've told you, paradiscal is the most common site affected. So the first sign on an X-ray would be decreased disc space. So please remember, the first sign on an X-ray of a TB spine would be decreased disc space. This is very much important. The first sign on an X-ray of TB spine is what? Decreased disc space. And this is also important. Most common site is your paradiscal. Okay, important one. Now, what do we do for treatment? Definitely we'll give ATT, that is your anti-tubercular therapy. So this is usually given for 3 weeks. And after 3 weeks, we check for recovery. Okay, after 3 weeks we check for recovery. If recovery is present, we continue the ATT. Okay, so please remember, if ATT like recovery is present, we continue the ATT for 9 months, and if recovery is absent, then we move on to a surgery. And which is the surgery preferred? So please remember, in cases of TB spine or POT spine, the surgery is your decompression surgery. Okay, it is your decompression surgery. I hope now POT spine or TB spine is very much clear to you. Now the answer to this question, it would be what? Which is the earliest neurological deficit seen? The earliest neurological deficit seen would be option A, motor. Okay. Now moving further to our next question, guys. Question number 4. Which among the following bone undergoes intramembranous ossification? So this is an overlap question between anatomy and orthopedics. It can be asked either in paper 1 or in paper 2. Okay. So this is very much important to be remembered. Like, as we all know, all the bones undergoes ossification. Some of the bones undergo ossification in the membrane, within the embryonic membrane. Therefore, it is known as intramembranous ossification. And some of the bones undergo ossification within the hyaline cartilage. Therefore, it is known as enchondral ossification. So just tell me your answer. Which among the following bone undergoes intramembranous ossification? Any answer to this question, guys? So type in the chat box. So in meanwhile, let's discuss. I have told you intramembranous ossification, when bone undergoes ossification within embryonic membrane, What are the bones which undergo intramembranous ossification? So please remember, all the flat bones. Okay, so flat bones, usually like your skull bone or your facial bones, they usually undergo intramembranous ossification, right? Flat bones like skull or facial bones, along with a long bone. Okay, so please remember, along with a long bone, that is your clavicle. So please remember, clavicle, though it is a long bone, it undergoes intramembranous ossification, whereas all other long bones, they undergo enchondral ossification, except clavicle. Okay, right? So the answer over here would be, please tell me. So enchondral ossification, it is within hyaline cartilage. Any answers now? It is very much clear. Intramembranous ossification, flat bones. Which is the flat bone among your skull and facial bones? Humerus is a long bone. Ischium, it is a pelvic bone which usually undergoes enchondral ossification. Okay. Next is your sternum. It also undergoes enchondral ossification. So the answer over here is a facial bone, that is mandible. So please remember, option B, mandible, is the right answer, which undergoes intramembranous ossification, right? Now just talking a few points about your ossification center. As we all know, the ossification usually starts at the ossification center. There are two ossification centers. First is primary and second is secondary. Right, so primary ossification center appears in the intrauterine life. Okay, so primary ossification center appears in the intrauterine life, whereas secondary ossification center appears after birth. Okay, important point to be remembered is, all long bones usually have single primary ossification center, whereas multiple secondary ossification center. Again, exception would be clavicle. So clavicle एक ऐसा bone है which has two primary ossification centers and only single secondary ossification center. Okay, this is the exception that you need to remember. Then primary ossification center is usually located at the center of the bone, okay, in the diaphysis, whereas the secondary ossification center usually is located at the ends of the long bones, that is at the epiphysis, right? So please remember this. I hope this helps you. Now moving further, and which is the only secondary ossification center which is present at birth? Usually secondary ossification center appears after birth, right? So the only secondary ossification center present at birth is what? It is your distal end of femur. So please remember, distal end of femur is the only exception where the secondary ossification center is present itself at birth. Next question is question number 5. Bone is mainly composed of which inorganic crystals? So here you need to know about the composition of the bone, and the options are: option A, calcium carbonate; option B, sodium bicarbonate; option C, calcium hydroxyapatite; option D, magnesium phosphate. And your answer, guys? So composition of bone is very important to be remembered. Normally, what is a bone made up of? So please remember, usually a bone is made up of some of the bone cells and a extracellular matrix, right? Usually 10% are your bone cells and rest 90% is your extracellular matrix. right? It is your extracellular matrix. There are three types of bone cells usually. Okay, which are these three types of bone cells? First are your osteoblasts. Okay, by blast you can understand that these are your immature cells, right? Most of the times blasts are your immature cells. So osteoblasts are your immature bone forming cells. Okay, these are your bone forming cells, right? And one feature that you need to remember, that these bone forming cells or osteoblasts, they are rich in alkaline phosphatase, as there is high metabolic activity inside them. Second are your osteocytes. By sites you can know these are your mature bone cells. Okay, these are your mature bone cells, and they are rich in glycogen. They are rich in glycogen. They have lot of glycogen content, and therefore they stain positive for PAS. So they are PAS positive. Wherever glycogen would be present, that substance or that structure would be PAS positive. So please remember, as they have high amount of glycogen, they would be PAS positive. And last, third type of cells are your osteoclasts. Okay, so please remember, osteoclasts are nothing but bone monocytes, or we can also call them as bone macrophages, because their primary function is what? Phagocytosis. Okay, so phagocytosis, and these are also known as bone resorption cells. ठीक है, ये bone को खत्म करते हैं. ऑस्टियोब्लास्ट्स को बोन को बनाते हैं, whereas ऑस्टियोक्लास्ट्स बोन को खत्म करते हैं. That is bone resorption cells. Okay, bone resorption cells. So important one. Now coming to your crystals actually. So extracellular matrix is 90%, out of which we have 25% of organic component and 65% of inorganic component. So this actually organic component is what? It is your proteins. And what is the inorganic component? It is your minerals, right? So the 25% of organic component or your proteins, which is the most abundant protein in your bone? So please remember, it is your type 1 collagen. Important. Which type of collagen is present in bone? So please remember, it is type 1 collagen. Okay, type 1 collagen is present in bone, ligaments, tendons and skin. Very much important. Type 1 collagen is present in bones, ligaments, tendons and skin. Type 2 collagen is present in cartilage. Type 2 collagen is present in your stage of hematoma. First is your stage of hematoma, where what happens? So this stage of hematoma actually lasts for how many days? It actually lasts for 7 days. So please remember, where we can see precursor cells. Okay, we can see precursor cells for the repair. Next is your stage of granulation tissue. This stage of granulation tissue usually lasts for 2 to 3 weeks. It usually lasts for 2 to 3 weeks. Okay, in this stage of granulation tissue we can see presence of fibroblasts, we can see presence of osteoblasts, and we can also see new blood vessels. Okay, and as there is presence of new blood vessels, this granulation tissues gives a velvety appearance. This granulation tissues gives a velvety appearance. Please tell me guys, if there is any internet issues, internet connectivity issues, just let me know, so we can just work on it right now. Okay, if you are facing any issues, then stage of granulation tissues lasts for how many weeks? It lasts for usually 2 to 3 weeks, where there is presence of fibroblasts, osteoblasts and new blood vessels. The next one is your stage of callus formation. According to me, this is the most important stage. Please remember, you should not forget the stage of callus formation. What do we mean by callus? So please remember, callus actually means the immature bone. So please remember, actually immature bone is formed where? In the stage of callus formation. Okay, so in stage of callus formation, it usually starts at what time? So please remember, it usually starts at end of 3 weeks, that is around 21 days. Okay, so callus formation usually starts at end of 3 weeks, or usually 21 days, and it persists for how many months? So please remember, it usually takes 2 to 3 months for this stage to complete. Okay, this stage lasts for around 2 to 3 months. Remember this. Okay, and callus formation, when it occurs, it makes the fracture immobile. Before callus formation, the fracture would be mobile. Okay, it can be displaced, but after callus formation, the fracture would be immobile. Okay, and please remember one more important point. This is the earliest radiologically visible stage. This is the earliest radiologically visible stage. So please remember, what is the answer to our question? The first or the earliest radiologically visible stage of fracture healing is what? Option C, callus formation. Important point to remember is, it starts at end of 3 weeks, that is 21 days, and it lasts for around 2 to 3 months. Okay, please remember this. Now comes the stage of remodeling. Stage of remodeling actually lasts for how much time? It usually lasts for around 1 year. Okay, and now the callus or the immature bone which was formed, it is now converted to a compact or a lamellar bone. The normal bone of the cortex, that is your compact or lamellar bone. I hope now you know two types of bone are there, right? First is your woven, spongy or cancellous bone, right, which contains trabeculae and which is usually present at the metaphysis. And second type of bone is your compact or lamellar bone, which is made up of your osteon and it makes up your diaphysis or the shaft of the bone, right? I hope this you are clear with. Next is your stage of modeling. Stage of modeling, it takes usually many years, okay? It usually takes many years and it makes the fracture indistinguishable to the normal bone, okay? अभी fracture लगेगा ही नहीं, okay? कभी fracture हुआ था ऐसा. So it becomes indistinguishable to the normal bone, right? Now moving further, I hope the answer to this question is very much clear. Moving further now, the next one is your question number 7. A patient was a case of compound fracture and the treatment was requiring a flap to cover the wound. Which grade of Gustello-Anderson's classification is this classified into? So please tell the answer. As you all know, Gustello and Anderson's classification is usually used for open or compound fractures, okay? Whenever we have an open or a compound fracture, we have your Gustello and Anderson's classification. Then we proceed to further treatment, right? So now, according to this, what is the grade? So please remember, just understand the important grades, okay? So Gustello and Anderson's classification is classified as grade 1 when the wound size is less than 1 centimeter, okay? Grade 1 when the wound size is less than 1 centimeter. Grade 2 when the wound size is between 1 to 10 centimeters. Grade 2 when the wound size is between 1 to 10 centimeters. Grade 3A is when flap is not required, okay? Flap is not required to cover, okay? So please remember, if flap is not required to cover the injury or the wound, then it is considered grade 3A. And what is the treatment of choice for grade 3A? So please remember, usually we prefer debridement, and in some conditions we need to perform internal fixation. So debridement along with internal fixation is the treatment of choice for grade 3A, and we do not use any flap. When a flap is required, to cover the injury or the wound, then it is classified as grade 3B. When a flap is required, it is classified as grade 3B. And lastly, when there is a vascular injury, okay, irregular of the wound size, now if there is a vascular injury to any vessel, then it is classified into grade 3C. So please remember, answer over here, what is the treatment was requiring flap to cover the wound. Therefore the answer would be what? The answer to this question would be option C, that is grade 3B, because it requires a flap to cover the wound. I hope this is clear to you now. Moving further to our question number 8. A pedestrian while crossing the road was hit by the car and suffered an injury, okay? He was hit by the car and suffered an injury at the lateral aspect of the leg. The splint used in the following condition is as shown in the image is. So इस splint का नाम पूछा गया है. What is this splint known as? But they have just given a history, okay? So please remember guys, a pedestrian is crossing the road and while crossing the road he is hit by a car. I have already explained this scenario to you, right? He is hit by a car. This is your car. And what is this area of the car? It is your bumper. So this can lead to what? If the bumper hits your patient, it can lead to a bumper's fracture, okay? It can cause a bumper's fracture, or it can cause what? It can cause fracture of the neck of your fibula. What do we have at the lateral aspect of your leg? We have your fibula. So the neck of fibula can be fractured. And which is the nerve which wounds around the neck of the fibula? We all know now. Which is the nerve which wounds around the neck of the fibula? Please remember guys, in this condition, mostly the most common nerve injured is your common peroneal nerve, which wounds around the neck of fibula. And as common peroneal nerve is injured, that can lead to paralysis of your tibialis anterior muscle. And tibialis anterior muscle is responsible for active dorsiflexion of the foot. And as this active dorsiflexion of the foot is lost, the foot would go in this position. And what is this position of the foot known as? This position of the foot is known as what? It is known as foot drop, right? So the dorsiflexion would be lost. This position is known as your foot drop. So common peroneal nerve injury can lead to foot drop. So this is a splint actually used in cases of foot drop. Which is the splint? So let's discuss some splints and then come back to this now. Okay, this images are very much important, guys. One of this image, this one has come in this FMG June 2021 session right now. Okay, so first splint that we can see over here, what are these? Okay, these are your Kramer wire splint or your K wire splint. What are these? These are your Kramer wire splint or K wire splint. These are used over here to reduce the fracture of your distal end of the radius over here in this condition. Okay, so please remember these are your Kramer wire or K wire splints, usually used for your smaller fractures. What is this? The second splint you can see over here, very much important. This is your Dennis Brown splint. कौन सा splint है ये? Dennis Brown splint. And Dennis Brown splint is used for what? So it is not actually used for treatment, it is used after treatment. Okay, so when we perform a treatment, after treatment for maintenance, we give this Dennis Brown splint in cases of CTEV, that is congenital talipes equinus varus, also known as club foot. So please remember this is usually given in cases of club foot, Dennis Brown splint, okay, which maintains CTEV. Next, the third splint over here, it is very much important again. Okay, what is this? It is bending your knuckles. Okay, these are your knuckles, it is bending your knuckles, therefore it is known as your knuckle bender splint. This is what? This is your knuckle bender splint. And knuckle bender splint is used in cases of ulnar nerve injury. Ulnar nerve injury leads to what? Ulnar nerve injury leads to partial claw hand, right? So in cases of partial claw hand or ulnar nerve injuries, we can use this knuckle bender splint. Yes, it is also given in cases of claw hand, which is due to ulnar plus median nerve injury. याद रखना, ulnar nerve injury only leads to partial claw hand. Ulnar plus median nerve injury leads to claw hand. Okay, mistakenly बहुत बार हम ulnar claw hand ऐसा याद कर लेते हैं. Next one is what? Over here. हाथ कैसा है? ऊपर ऐसा cocked up है. Okay, so this is known as your cock up splint. Okay, cock up splint usually given in cases of radial nerve injury. Radial nerve usually innervates what? It usually innervates the posterior aspect of your arm, forearm and hand. Okay, so if the radial nerve is injured, it can lead to what? It can lead to wrist drop. It can lead to wrist drop. And therefore in cases of wrist drop, the treatment given usually is this, your cock up splint. Okay, next one is your aeroplane splint. And aeroplane splint is used in cases of brachial plexus injury. It is used usually in cases of brachial plexus injury. This is your aeroplane splint. Next is your Milwaukee and Boston's brace. Milwaukee and Boston's is a spinal brace given for scoliosis. Next is your Taylor's brace given for thoracolumbar spine. Okay, this is your Taylor's brace usually given for thoracolumbar spine injuries. And last is your AFO. What is AFO? That is your ankle foot orthosis. Okay, AFO is ankle foot orthosis, also known as foot drop splint. Also used in cases of common peroneal nerve injury. This is used in cases of common peroneal nerve injury, which can lead to foot drop. Right? This is what we have discussed in the question. The common peroneal nerve injury leads to foot drop, in which this can be used. What is this? This is your ankle foot orthosis or foot drop splint. So what is the answer over here now? So the answer over here is option B, AFO or ankle foot orthosis. Right? Now moving further to our next question, question number 9. The below given attitude of limb is seen in which type of hip dislocation? Okay. So what is this attitude of limb? पहले तो ये देख लेते हैं. Okay, what is this? What we can see over here? क्या दिख रहा है? सबसे पहले तो यहाँ पे flexed है. Okay, so first of all there is flexion. Okay, first of all there is what? There we can see flexion. Second what we can see? Second यहाँ पे क्या है? पैर किसकी तरफ है? So please remember, where is the leg? Leg is inside. Therefore this is what? Adduction. Okay, this is what? This is your abduction. Okay, leg is outwards, right? Leg is outwards. This is your abduction. And the leg is also externally rotated. So this is your external rotation. So this is your flexion, abduction and external rotation seen. Okay, the attitude कैसा दिख रहा है? Flexion है, right? Abduction है, away from the body, and there is external rotation. You can see over here, right? So this is Faber, and Faber is seen usually in conditions of which hip dislocation? Faber is usually seen in condition of anterior hip dislocation. Very good. So anterior hip dislocation, option A is your answer. So just discussing important few points about your hip dislocation. As we all know, hip is your strongest joint, okay, but it is also one of the commonly dislocated joints, right? Hip dislocation occurs usually in cases of high velocity trauma. whenever there is a high velocity injury or a high velocity trauma like the road traffic accidents, hip dislocation can be seen. Okay. Next, first of all, there are usually 4 types of hip dislocation: posterior, anterior, central fracture hip dislocation, and superior. Inferior is not usually seen. So the posterior hip dislocation, please remember guys, it is the most common type of hip dislocation. So अगर question आता है which is the most common type of hip dislocation, the answer should be posterior hip dislocation. Okay, it is usually seen in cases of dashboard injury. When a driver is driving a car and he suddenly applies a brake, what happens usually is the knee, it goes and hits to the dashboard. When there is such a high velocity trauma to the knee, the femur is actually forced posteriorly, okay, and that can lead to this posterior hip dislocation. The femoral head would be dislocated posteriorly. This is usually seen in cases of dashboard injury, okay, dashboard injury. Okay, please remember this. Next, what would be the attitude of limb? So the attitude of limb over here would be flexion, adduction, and internal rotation. That is father. How do I remember this? Father. Okay, it sounds similar, right? Father, and P goes for papa. So that is how I remember it. It depends on you how to remember it now. Okay, so this is how I remember it, father and papa. So this is how, like, the attitude of limb, that is father, is usually seen in cases of posterior hip dislocation. What would be the treatment of choice? Usually in cases of dislocations, what is the treatment of choice? It is your closed reduction. Okay, and if the closed reduction fails, then only we go for open reduction. Okay, so closed reduction is usually done by various techniques. What are the various techniques with which closed reduction of posterior hip can be done? So please remember, it is known as your Ali's technique, Stimson's technique, and last is your Bigelow's technique. And Bigelow's is very much important. Why? In cases of Bigelow's technique, which ligament would be used? We would use the Bigelow's ligament. And which is the Bigelow's ligament? It is your iliofemoral ligament. Why it is important to remember this iliofemoral or your Bigelow's ligament? Because it is the strongest ligament of the body. So please remember, strongest ligament of the body कौन सी है? Iliofemoral ligament or Bigelow's ligament. And strongest joint कौन सा था? Hip joint, right? Now, which is the most common complication usually associated? So please tell me, which is the most common complication associated with this posterior hip dislocation? So please remember, the most common complication associated would be AVN, that is your avascular necrosis. If the blood supply is cut off, that can lead to avascular necrosis usually, right? So avascular necrosis usually occurs if the closed reduction is not done within 6 hours. If the closed reduction is not done within 6 hours, then that can lead to avascular necrosis of the femoral head. Okay. Next is your anterior hip dislocation. So anterior hip dislocation, the attitude of the limb would be what? Attitude of the limb would be Faber, that we have already seen. I'll show you the image. And last is your central fracture dislocation. So what happens? Centrally, the femur head cannot go, right? Because centrally what is placed? There is your acetabulum. So this is how a joint is formed. This is your acetabular cup and this is your femoral head. So now what happens? If the acetabulum gets fractured, then the femoral head can dislocate centrally, right? Therefore it is known as central fracture dislocation, because there should be a acetabulum fracture, then only a central dislocation can take place, right? So there is a acetabulum fracture along with a central dislocation. And what is the treatment usually in cases of central fracture dislocation? We usually perform a lateral traction. We usually give a lateral traction to this patient. I hope. Now over here you can see, यहाँ पे ये एक्सरे देख सकते हो, क्या दिख रहा है? The femoral head is displaced posteriorly from the acetabular articulation, right? So this is your posterior dislocation of hip, usually seen in dashboard injury. And what is the attitude of limb? We can see over here. यहाँ पे क्या दिख रहा है? First of all, we can see flexion is seen. Okay, first we can see there is flexion. Second, the limb is adding to the body. It is towards the body. Therefore, this is known as what? This is known as your adduction. And last, what we can see, the foot is, or the leg is what? It is internally rotated. So what is the attitude of limb in posterior hip dislocation? It is your fader. So please remember, flexion, adduction and internal rotation is usually the attitude of limb in cases of posterior hip dislocation. What would be the attitude of limb in cases of anterior dislocation of hip? You can see the X-ray over here. The femoral head is displaced anteriorly, okay? It is dislocated anteriorly from the acetabular cup. In this, what is the attitude of limb? We can see flexion, okay? The leg is going away from the body, that means abduction, and the leg is externally rotated, that means flexion, abduction, external rotation. Faber. So please remember, Farder is associated with posterior hip dislocation and Faber is associated with anterior hip dislocation. So what is the answer over here? It is your option A, anterior hip dislocation. Moving further to our question number 10, guys. Here the question states, a 4-year-old child fell from the stairs and sustained a fracture. The radiograph image is given below. Which is the preferred treatment in this patient? So what we can see over here, guys, यहाँ पे क्या दिख सकता है? This is your pelvis, ये दिख रहा है ना? This is your ischial fossa जो दिख रहा है तुम्हें. And what you can see, this is your femur, right? And fracture कहाँ पे है? ये है तुम्हारी fracture line. So fracture is where? Fracture is at the diaphysis, right? Fracture कहाँ पे है? Diaphysis, also known as shaft. So the fracture is actually at the shaft of femur. Okay, fracture कहाँ पे है? Fracture is at the shaft of femur, right? So now let's discuss few important treatment options for fracture shaft of femur, right? So the few treatment options that you need to remember at any cost for fracture shaft of femur, okay? So usually fracture shaft of femur, again femur is a very strong bone. Only fracture of the shaft that too occurs in cases of high velocity trauma, when there is fall from height or when there is a road traffic accident usually, right? Now there is a Winquist and Hansen's classification, okay, for fracture of shaft femur treatment, okay? According to this Winquist and Hansen's classification, the treatment for this fracture is classified age wise, okay? So if the patient is less than 2 years of age, we usually prefer a Gallows and Bryant's traction. What we prefer? We prefer a Gallows and a Bryant's traction, okay? I'll show you the image. If a child is less than 2 years of age, usually in cases of fracture shaft of femur, we prefer a Gallows and Bryant's traction. If the child is between 2 to 5 years of age, then we prefer a hip spica cast, okay? Then we prefer a hip spica cast usually. A POP cast is applied, right? Next one, if the child is between 6 to 14 years of age, okay? If the child is between 6 to 14 years of age, then the treatment is TENS. What do we mean by TENS? TENS means titanium elastic nailing system. What do we mean by TENS? Titanium elastic nailing system. I'll show you the image for this also. Okay, this is done when the child is between 6 to 14 years of age. And when the child is more than 14 years of age, or in case of adults, what is the preferred treatment option? It is your interlocking intramedullary nail. What do we prefer? We prefer a interlocking intramedullary nail within the bone marrow cavity. Okay, so please remember, interlocking intramedullary nail is preferred if the child is more than 14 years of age or if there is any adult, right? What are the most common complications? Before going to the question, just remember the important complications for fracture shaft of femur. So immediate complication would be what? As we all know, fracture shaft of femur is femur is the longest bone. It is highly vascular. It contains many blood vessels which supplies it. So if there is fracture shaft of femur, and along with it, near the femur, there are very important or bigger blood vessels which are located, the major blood vessels. So if there is fracture shaft of femur, that can lead to transaction of these blood vessels, leading to massive blood loss, okay? And this massive blood loss usually seen in cases of fracture shaft of femur. कितना होता है? It is around 1000 to 1500 ml, okay? So the approximate blood loss in fracture shaft of femur is around 1000 to 1500 ml. This is a massive blood loss, and massive blood loss can land up the patient into hypovolemic shock. So please remember, the immediate complication of fracture shaft of femur would be hypovolemic shock. And what would be an early complication then? Early complication usually within 1 or 2 days or 3 days. So usually after fracture shaft of femur, a patient within 48 to 72 hours presents to you with respiratory distress or dyspnea. Okay, after this fracture, the patient within 48 to 72 hours presents to you with respiratory distress. Okay. No, avian would be a late complication. It is not an early complication. It does not occur within days. It takes a long time to occur. Avian. Early complication would be like within days. So within 48 to 72 hours, if the patient presents to you with very good, Srini, it is your fat embolism syndrome. Important one, it is your fat embolism syndrome. So as we all know, long bones have a marrow cavity. So as femoral shaft gets fractured, there are fat globules in this marrow cavity. These fat globules get dislodged and go into the circulation. Once they go into the circulation, they go and lodge in the pulmonary microvasculature. Pulmonary circulation में जाते हैं and वहाँ पे वो क्या करेंगे? There it causes toxic vasculitis. Okay, it causes toxic vasculitis leading to this respiratory distress. Okay, so please remember this fat embolism. This is your fat embolism syndrome. Now moving back to our question, what is the age of the child over here? The child is 4-year-old, matlab between 2 to 5 years, right? So what is the preferred treatment over here now? Now you can answer it. Option, the treatment over here would be option B. That is your hip spica cast. Let's see the images for this. Okay, so ये तो है तुम्हारा central fracture dislocation. I told you the acetabular fracture occurs and the femoral head moves or it immigrates inside the pelvic cavity. This is your central fracture dislocation. Okay, talking about the last question. Okay, yeah, talking about the last question, these are your important ones. Okay, less than 2-year child, what we prefer? We prefer Gallows and Bryant's traction for a femoral shaft fracture. This is your Gallows and Bryant's traction. Okay, this is how it is applied. Gallows and Bryant's traction. So this is a treatment option between 2 to 5 years of age. What we can see over here, this is your hip spica cast. Okay, this is your POP cast which is applied. This is unilateral, this is 1.5, and this is a bilateral hip spica cast. And this is what? This is your titanium elastic nailing system, also known as TENS, for children between 6 to 14 years of age. Again for femoral shaft fractures, right? So this is your titanium nails. So see, this is elastic. Okay, elastic है, ठीक है, interlock कर दिए ऐसे nails. And this is your avian. Okay, this is your avian भी देख लो यहाँ पे. This X-ray shows you bilateral avascular necrosis of femoral head, which is a late complication for fracture neck of femur. याद रख लेना, it is a late complication for fracture neck of femur. Okay, this is how you can see over here. Okay, increased opacity is seen, right? Increased opacity is seen. Moving further to our next one. Question number 11. A patient met with a road traffic accident and sustained a fracture. On examination, blood pressure is 88 by 56 millimeters of mercury and pulse rate is 130 per minute. The estimated blood loss was around 2000 ml. Which fracture is this condition most likely associated with? So they are asking, like, this massive blood loss of 2000 ml or 2 liters is usually associated with which fracture? Can anybody tell me? Massive blood loss is associated with which fracture? One we have already studied, it is your femur fracture. But in femur fracture, I told you the blood loss was around how much? It was around 1500, like 1000 to 1500 ml, right? Over here it is exceeding that. It is around 2000 ml. The answer over here is, very good Srini, the answer over here is option C, that is your pelvic fracture. Okay, it is your pelvic fracture. Yes, very good. Okay, important one, pelvic fracture. Now let's discuss some important complications of fracture. Okay, complications of fracture are always important, guys. ठीक है, केस दिया जाता है, वन लाइनर्स पूछे जाते हैं इसमें से. And this is a classification which I have found very useful to remember it. I hope this also helps you out now. Okay, so usually complications of fracture are classified as immediate complications, early complications and late complications. Okay, let's see one by one now. So immediate complication क्या हो सकता है? Either there can be injuries to the blood vessels, to the nerves and also to the adjacent tissues or your soft tissues, right? So this can be one of the immediate complication. Second immediate complication would be hypovolemic shock, that we have already seen, right? What happens in hypovolemic shock? It is a state of hypoperfusion. It is a state of hypoperfusion. Blood supply कम जाता है organs तक, right? Because there is decreased cardiac output. So in this case, as there is decreased cardiac output due to excessive blood loss, there can be what? There would be hypotension, which was seen in our patient, right? Blood pressure कितना था इसका? 88/56. Okay, what is the cutoff? 90/50 is usually the cutoff, right? So इसका systolic कम है, so it is your hypotension. Along with there is a reflex tachycardia. Whenever there is hypotension in cases of hypovolemic shock, there is a reflex tachycardia, heartbeat more than 100, which is usually seen over here. Pulse rate, it is how much? It is 130, right? So this is the characteristic case of hypovolemic shock, how it usually presents to you, right? Most common fracture which is associated with hypovolemic shock is your pelvic fracture. याद रखना, the most common fracture which is usually associated with hypovolemic shock is your pelvic fracture, followed by the second most common is your femoral shaft fracture. Okay, pelvis fracture में कितना होता है blood loss? Around 1500 to 2000 ml, and in cases of femoral fracture it is around 1000 to 1500 ml. I hope this is helping you out. Okay, important one, guys. Now, what is the management usually in cases of hypovolemic shock? So if there is a pelvic fracture, guys, usually in pelvic fracture the primary management is to apply a pelvic binder. सबसे पहले क्या करोगे? If you are at a like what we can say at accident site and you suspect that the patient has undergone a pelvic fracture and there is a massive blood loss occurring, what is the primary thing you do? You will apply a pelvic binder. Definitely you will not have a pelvic binder at that place, therefore you can apply a dupatta or anything, only cloth you can apply. You can tightly just tie that cloth around the waist of the patient or around the pelvis of the patient, which will minimize the blood loss. Okay, so that is apply a pelvic binder, followed by infusion, that is your IV fluids. Intravenous fluids are given, and both IV fluids are given, that is crystalloids as well as colloids. Crystalloids क्या होता है? That is a saline, ringer lactate, all of these are your crystalloids. And colloids क्या होता है? That is your proteins like albumin, right? So both of these would be given, and finally you will apply a external fixator. Finally you will apply a external fixator. Now in cases of hypovolemic shock, what is the best replacement? Blood loss हो रहा है, so best replacement would be what? Best replacement I am asking, not the usual replacement. Usual replacement तो कोई भी fluid चढ़ा दो. Okay, you can give NS also, you can give ringer lactate also. Okay, what is the best replacement? But अगर blood loss हुआ है, best replacement would be blood, right? Blood itself. Therefore blood transfusion is the best replacement. Please याद रखना. Okay, blood transfusion is the best replacement. And what is the best indicator of volume resuscitation? What we can see, the fluids, or you can you are giving your blood transfusion, then the volume is being resuscitated, right? Volume तुम normalize कर रहे हो, and what is the best indicator? तुम्हें कैसे पता चलेगा कि volume normal हो गया है? So the best indicator of volume resuscitation is what? The best indicator is your urine output. This question was asked previously, guys, so please remember. Okay, from medicine also it can be asked. The best indicator of volume resuscitation is your urine output. Adequate urine output होना चाहिए usually. Okay, so please remember this. Now talking about your early complications. First is your ARDS. Okay, what happens in ARDS? ARDS is your acute respiratory distress syndrome. Okay, respiratory distress होता है. It usually happens in cases of polytrauma. Whenever there are multiple injuries, okay, in cases of polytrauma, what happens? There is excessive release of inflammatory mediators, and this excessive release of inflammatory mediators can lead to a syndrome known as SIRS, that is systemic inflammatory response syndrome. Okay, and this SIRS can also damage your pulmonary circulation. These can also damage your pulmonary vasculature, leading to your ARDS. Okay, ARDS में usually क्या दिखता है हमें? Diffuse alveolar damage is seen. On an X-ray we can see ground glass opacities, right? So this is the cause for ARDS in cases of fractures or in cases of polytrauma. Next is your fat embolism syndrome, which I have already explained. 48 to 72 hours after a fracture of a long bone, usually in cases of fracture shaft of femur, in these cases the fat globules are released, which will go and cause toxic vasculitis in pulmonary circulation, leading to respiratory distress. Time important है, याद रखना, 48 to 72 hours after a fracture of femur. Next is your DVT, that is your deep venous thrombosis. DVT की एक चीज़ याद रखनी है तुम्हें, it is due to a history of prolonged immobilization. So usually prolonged immobilization कब कराया जाता है पेशेंट का? बेड रेस्ट कब दी जाती है? फॉर लॉन्ग पीरियड ऑफ टाइम, लाइक फॉर मंथ्स टुगेदर. It is usually given in cases of spinal injuries, right? In cases of spinal injuries, or in cases of THR, that is total hip replacement or total knee replacement. So please remember, in cases of total hip or total knee replacement surgeries, or in cases of spinal injuries, the patient would require a prolonged bed rest. Okay, he will be under prolonged immobilization, which will lead to stasis of blood in the veins of your lower limb. Okay, there would be stasis of venous blood in the lower limb, which can predispose to formation of a thrombus. Thrombus बन जाएगा उसमें, right? Stasis होगा blood का तो. So this thrombus formation is usually seen after prolonged immobilization, and this condition is known as your deep venous thrombosis, for which usually the investigation of choice is a color Doppler, and treatment is usually compression stockings or sclerotherapy. You will read it in surgery. Okay, anyways, moving further to our next is your Crush syndrome. Crush syndrome में क्या होता है? There is laceration. Okay, there is a lacerated injury of all your soft tissues. Okay, और soft tissues bone के आसपास क्या होते हैं usually? They are your muscles, right? So there is actually what? There is a traumatic rhabdomyolysis. What do we mean by this term rhabdomyolysis? नाम से पता लगा लो, so it would be easier. Traumatic मतलब due to trauma. Rhabdomyo. Rhabdo means striated या skeletal. Myo means muscle. Okay, lysis means breakdown. So this is rhabdomyolysis, means breakdown of your skeletal muscle or striated muscle. Once these skeletal muscle or striated muscle break down, they release a protein known as what? Striated muscles में usually कौन सा protein होता है? They release a protein known as myoglobin, which is a high molecular weight protein. And this high molecular weight protein myoglobin, once it is released into the circulation from these muscles, now this would go to kidney for filtration. Finally सब कहाँ जाते हैं? Kidney में जाता है. And once it goes to the kidneys, the glomeruli could not filter it out properly, and that can lead to kidney injury. Okay, and that can land up the patient into acute renal failure. Okay, please remember, Crush syndrome usually the patient can land up into acute renal failure. Next one is your compartment syndrome. What happens in compartment syndrome? एक चीज याद रखनी है, it is usually seen in cases of closed fracture. Compartment syndrome is usually seen in cases of closed fractures. In that, what happens whenever there is a hematoma formation or there is a muscle edema, or we apply a very tight plaster of Paris bandage. Okay, in these conditions what happens is there is a rise in the pressure in this osteofacial compartment. What do we mean by this osteofacial compartment? As you all know, there is bone, then there are muscles, and there is a covering fascia over it, right? So bone और fascia के बीच में क्या होती है? Muscles. So this is known as your osteofacial compartment. So whenever there is hematoma around over here, or there is muscle edema, that can cause rise in pressure in this compartment. That can lead to this compartment syndrome. Usually in cases of compartment syndrome, due to this excessive pressure, there can be compression of the blood vessels or your nerves. Okay, there can be compression of your blood vessels or nerves that can lead to further injury. That can lead to further what can say symptoms. Moving further to a last, that is your late complications of fracture. And late complications of fracture can be what? Usually shortening. ठीक है, ढंग से वो fracture जुड़ा नहीं. That is malunion happened. Okay, so malunion of the fracture happened, which led to shortening, right? Next one is your AVN, that is avascular necrosis. As the blood supply was cut off, usually avascular necrosis took place. Okay, that is a late complication, guys. Next is your myositis ossificans. Usually what happens after a fracture, if you keep on massaging, okay, if you keep on massaging at the site, it can lead to ossification of the muscle. Okay, ossification within the muscle is known as myositis ossificans. And last is your Sudex osteodystrophy. Okay, we have one question for Sudex, we'll discuss it over there. Okay, next, what is non-union? So please remember, we have discussed about callus formation. Callus formation usually begins within, like, at the end of 3 weeks, right? But if callus formation is not seen beyond 6 months also, then this condition would be known as delayed union. अगर callus formation हमें 6 महीने के बाद भी नहीं दिख रहा है, then it is known as delayed union. And if callus formation is not even seen after 9 months, then this condition is known as non-union. Okay, if callus formation is not even seen after 9 months, then this condition is known as non-union, for which usually we perform internal fixation with a bone grafting. And the most common site of bone graft, again a very common question which has been asked. The most common site of bone graft is what? It is your iliac crest. याद रखना, it is the most common question which is asked. Most common site of bone grafting is what? It is your iliac crest. Moving further to our question number 12, guys. Now, I hope, yeah, we have answered the question. Question number 12 states, an 8-year-old child was brought to the ortho OPD with fever and acute pain over the thigh. On inspection, swelling is seen over the mid-thigh region, and X-ray ordered shows lamellated appearance, and immune histochemical staining is positive for MIG-2. What is your diagnosis? This is your X-ray, and X-ray they have said what? It shows lamellated appearance. मतलब क्या दिख रहा है? एक तो ये कहाँ पे है? This is a swelling at the shaft. Okay, कहाँ पे दिख रही है? Mid thigh region में बोला उन्होंने, और X-ray भी कहाँ दिखा रहा है? In the diaphysis या shaft में दिखा रहा है. क्या दिख रहा है हमें usually? We can see multiple layers. Okay, so this is what a lamellated appearance looks like. Lamellated मतलब क्या? Multiple layers. एक के बाद एक layers are seen. Okay, so what is the probable condition? What do you think of? याद रखना, यहाँ पे 8-year-old child है, that is it is the first decade of life. Okay, important. Second क्या बोला उन्होंने? There is fever associated, fever है. Third, there is acute pain over the thigh. Okay, swelling कहाँ पे? Mid thigh region में, मतलब shaft में है. And X-ray क्या दिखा रहा है? Lamellated appearance. Immune histochemical staining करी गई है. Immune histochemical staining is usually done in cases of tumors, right? And immune histochemical staining is positive for what? MIG-2. And we have discussed this in neoplasia. If you have gone through that lecture of mine, MIG-2 मैंने बोला था, MIG-2 or CD99 it is known as. It is the tumor marker for which bone tumor? So please remember, MIG-2 or CD99 is a specific bone tumor tumor marker for option D, Ewing's sarcoma. Please remember, this is very much characteristic. उन्होंने directly दे दिया MIG-2. Okay, so please remember, it is the most specific tumor marker for that is Ewing's sarcoma. Okay, along with that we will discuss important features about Ewing's, because Ewing's has been commonly repeated in the examination, guys. So please remember, we will be discussing important bone tumors. जो 3 important bone tumors है वो already question में दे दिया तुम्हें. Okay, so first is your Ewing's sarcoma. It is one of the most important bone tumor. Okay, it usually mimics osteomyelitis. What is osteomyelitis? Osteomyelitis is infection of your bone and bone marrow, right? It is your osteomyelitis. So it usually Ewing's sarcoma usually mimics a infectious etiology. वो लगता है कि कोई infection है, okay, but it is not usually an infection. It is a tumor of your bone, right? Now, what is the most common age group affected? So please remember, the first and second decade of life, okay, are usually affected in cases of Ewing's sarcoma. Ewing's sarcoma is more commonly seen in the first decade of life, that is first 10 years of life में दिखता है. Our patient was also how much? 8-year-old, right? So that was a like pointing thing, that was a keyword that you need to grab. Second, which is the most common site? So please remember, the most common site. What is Ewing's sarcoma? Ewing's sarcoma is a diaphyseal tumor. It is the tumor of shaft of the bone. It is a diaphyseal tumor. Which are the diaphyseal tumors? Please remember, it is Ewing's sarcoma, it is osteoid osteoma and adamantinoma. 3 important diaphyseal tumors तुम्हें याद रखने हैं. Ewing's sarcoma, osteoid osteoma and adamantinoma. Okay, which is the most common site? It is your diaphysis of bone. And which is the most common bone affected? The most common bone affected is the femur, that is shaft of femur or diaphysis of femur is the most commonly affected site. Most common translocation seen in this, so the most common translocation associated is translocation 11-22. Please remember, the most common translocation associated is translocation 11-22. And we have already discussed this. The specific tumor marker is what? Specific tumor marker for Ewing's sarcoma is MIG-2, also known as CD99, cluster differentiation factor 99. So MIG-2 or CD99 is the most specific tumor marker for Ewing's sarcoma. Important question from patho also. What does an X-ray shows us? So please remember, X-ray usually shows us what? X-ray usually shows us a lamellated appearance. ठीक है, ये तुम्हारा diaphysis है, यहाँ पे तुम्हें ऐसे lamella दिखेंगे, layer पे layer, okay? And it resembles what? This lamellated appearance resembles what? Onion peels, okay? प्याज के जो छिलके होते हैं उसकी तरह दिख रहा है ना, एक के अंदर एक. So therefore this appearance is also known as a onion peel appearance. So please remember, lamellated or onion peel appearance is usually seen in cases of Ewing's sarcoma. And what is the treatment usually? So please remember, Ewing's sarcoma is the most chemo as well as radio sensitive tumor. इस पे chemo भी चल जाती है, radio भी चल जाती है. So please remember, usually we prefer chemotherapy. Okay, we give pre-op chemotherapy. We give a pre-op chemotherapy, then we perform a wide excision of the tumor, and then again we give a chemotherapy for almost 1 year. Okay, in some cases radiotherapy can also be preferred. So now with this, I hope now you are very well acquainted with this fact that Ewing sarcoma usually presents as an infective etiology, like with fever, along with elevated ESR, along with elevated CRP. All these things can be given in the question, right? And usually it is the first decade in which the patient presents to you. Okay, moving further to our next question, question number 13. A 65-year-old man presents with chronic low back pain. Okay, chronic low back pain, 65-year-old. He has a history of multiple urinary tract infection in the past year. On examination, he has pallor and bony tenderness. His skull X-ray is given below. What is the most likely diagnosis? So ये skull X-ray हमें यहाँ दिख रहा है. What can be seen? We can see some punched out lytic lesions. क्या दिख रहा है हमें यहाँ पे? Punched out lytic lesions are seen. Now the question has become very simpler, right? We can see punched out lytic lesions. What is the likely diagnosis, guys? What have you marked in the question? Please tell me. So is this hyperparathyroidism? Usually in cases of hyperparathyroidism, where there is excess of parathormone, it causes resorption of bone. And if a skull X-ray of hyperparathyroidism is seen, it would not show punched out lytic lesions, rather it would show a salt and pepper skull. It would show a salt and pepper pot skull, you can say. Okay, salt and pepper skull can be seen. Next, in cases of eosinophilic granuloma, okay, eosinophilic granuloma is usually seen in cases of children. Okay, and eosinophilic granuloma usually presents with lytic lesions, but like not multiple punched out lytic lesions. It usually presents with the geographic skull. कैसे दिखता है वो? हमें geographic skull जैसा दिखता है. Okay, and osteoporosis circumscripta involves osteoporosis or demineralization of one of the part of the skull. यहाँ पे वैसा कुछ नहीं दिख रहा है, right? So this is what? Yes, option C, multiple myeloma. Very good, guys. Okay, so please remember few points about multiple myeloma. A very जितने स्टार्स मार्क्स कर सकते हो इस क्वेश्चन के लिए उतने मार्क कर लो. मल्टीपल माइलोमा इज द मोस्ट कॉमन एंड द मोस्ट इंपॉर्टेंट क्वेश्चंस विच हैव बीन आस्क्ड इन द रीसेंट टाइम्स. किसी भी एग्जाम में उठा के देख लो रिकॉल क्वेश्चंस, मल्टीपल माइलोमा का एक क्वेश्चन तो मिलेगा ही मिलेगा. Okay, so please remember guys, multiple myeloma is very much important. What is actually multiple myeloma? ओमा मतलब कोई तो ट्यूमर है, कोई तो proliferation हो रहा है किसी चीज़ का, right? So multiple myeloma सबसे पहले याद रख लो, it usually affects 60 to 70 years of age group. That is old age में affect करता है ये. Okay? ओमा है किसी चीज़ को, अभी ट्यूमर है, किस चीज़ का ट्यूमर है? So it is a tumor of plasma cells. Okay, so it is a tumor of plasma cells. What we can see? We can see plasma cytosis. What are plasma cells? Plasma cells are nothing but differentiated B cells or differentiated B lymphocytes. Okay, so B lymphocytes differentiates into plasma cells and they produce what? They produce antibodies, right? They produce antibodies or immunoglobulins. But in this condition, what is happening? Excessive plasma cells are being produced. Okay, excessive plasma cell produce हो रहे हैं, मतलब excessive B cells भी produce हो रहे हैं. So therefore, the bone is hyperproliferating. Okay, bone marrow is hyperproliferating. So bone marrow में जगह नहीं बची. Okay, so bone marrow is growing. Okay, so please remember this, bone marrow is growing faster. Okay, there is hyperproliferation occurring. So excess proliferation of B cells, excess proliferation of plasma cells which is seen, and lastly there would be excess of antibodies. But अब जल्दी जल्दी में बनेंगे तो ठीक बनेंगे क्या? ये नहीं बनेंगे, right? So the plasma cells which are formed, these are abnormal plasma cells and which will produce abnormal antibodies also. Normally antibodies or immunoglobulins contains two chains, that is heavy chains and light chains. But in conditions of multiple myeloma, what happens? These plasma cells will only produce light chains. Okay, these will only produce light chains of these antibodies. Okay, that is your kappa and lambda chains would be produced. Kappa and lambda chains would be produced, and the proteins which are formed with these are known as Benz-Jones proteins. Important question has been asked. Which are the proteins seen in cases of multiple myeloma? These are your Benz-Jones proteins. Okay, important one. Okay, now what are the important features that you need to remember, the clinical features? So 3 important features that you need to remember. First is your सीरम या यूरिन, अगर तुम इलेक्ट्रोफोरेसिस करते हो, इफ यू परफॉर्म अ सीरम और यूरिन इलेक्ट्रोफोरेसिस, नॉर्मली व्हाट यू कैन सी abundant amount of albumin, alpha globulin, beta globulin, gamma globulin. This is it, right? Albumin, this is alpha, beta and gamma globulin, that is your antibodies. But in this case, in cases of multiple myeloma, in serum or urine electrophoresis, you can see one more peak, and this is known as your M peak. Okay, so please remember, this is known as your M protein peak or M peak. These are due to this abnormal proteins which are being formed. Next is your bone marrow. Bone marrow में मैंने क्या बोला? There is hyperproliferation which is occurring. Okay, so bone marrow biopsy में usually will see plasma cells along with bony tenderness would be seen. Okay, along with bony tenderness would be seen. And lastly, there would be end organ damage. End organ damage in bone we have already seen. What we can see? We can see multiple punched out lytic lesions. Okay, multiple punched out lytic lesions are not only usually seen in an skull, but it is also seen in vertebrae and other sites. Okay, so याद रखना. Next, pallor बोला था question में, therefore it leads to anemia because excess of plasma cells are being produced in the bone marrow. दूसरे cells को बढ़ने की जगह ही नहीं मिल रही है, therefore decreased RBC is leading to anemia. Next, we can also see hypercalcemia. Important feature, we can also see hypercalcemia due to resorption of bone. ये जो lytic lesion हो रहे हैं bone के, that is increasing the calcium levels in the serum, right? We can also see increased creatinine, that is due to renal injury, right? And lastly, we can also see infections. Again, WBCs को भी बढ़ने की जगह नहीं मिल रही. These are abnormal antibodies which are being formed, जो कोई काम के नहीं है infection से लड़ने के लिए. Therefore, there are more infections which are usually seen in these patients, right? Now, these are some skull appearances, skull X-rays that you need to remember at any cost. Okay. So first is your Langerhans cells histiocytosis, where you can see 1 or 2 just lytic lesions in skull, usually seen in a 3 to 5 year old child usually. Okay, or we can say till 10-year-old child. Okay, Langerhans cells histiocytosis. Next one is your eosinophilic granuloma. In this you can see a map-like lytic lesion which can be seen, and this map-like lytic lesions can be seen at various places. Okay, and this eosinophilic granuloma gives an appearance of geographic skull. This gives an appearance of geographic skull. Okay, next is your multiple myeloma. यहाँ पे क्या दिखता है? Multiple punched out lytic lesions, and this multiple punched out lytic lesions in skull gives the appearance to the skull. And what is this skull now known as? This skull is also known as raindrop skull. So please remember guys, raindrop skull is seen in cases of multiple myeloma. Next one, इस image में क्या दिख रहा है तुम्हें? इस image में दिख रहा है कि almost this part, इसमें मिनरल डेंसिटी कम है, बोन डेंसिटी इसमें कम दिख रही है, राइट? इट इज थोड़ा रेडियोल्यूसेंट एज कंपेयर टू द नॉर्मल स्कल ओवर हियर, राइट? सो दिस कंडीशन जहाँ पे देयर इज ऑस्टियोपोरोसिस और देयर इज डिक्रीज मिनरल डेंसिटी, दिस इज नोन एज ऑस्टियोपोरोसिस circumscripta. This is known as osteoporosis circumscripta, usually seen in cases of Paget's disease. Next one, ये very common image which is again asked like multiple myeloma only, बहुत बार repeat हुई है. What can be seen over here? This is your hair on end appearance. What is this? Your hair on end appearance. And this hair on end appearance is usually seen in cases of thalassemia or any other hemolytic anemia. And last is, what is this? This is your moth-eaten skull. Okay, moth-eaten skull. यहाँ पे खाया जैसा लग रहा है ना, moth-eaten skull. This is usually seen in cases of bony metastasis. So अगर metastasis होता है किसी other primary tumor से, then it can lead to moth-eaten skull. Okay, I hope this is clear to you now. Okay, multiple myeloma is very much important guys, don't even dare to forget it. Now moving on to our question number 14. A 19-year-old man presented with progressive swelling of lower end of the femur. X-ray findings are as given below. Okay, these are the X-rays. CT scan of chest reveals osteoblastic metastasis. What is the most probable diagnosis? So इसमें मोस्ट प्रोबेबल डायग्नोसिस क्या है अभी देख लो. सो सबसे पहले तो क्या देखेंगे हम कि साइट कौन सी, पहले तो एज ग्रुप देखते हैं. एज ग्रुप कौन सा है? 19-year-old मैन, दैट इज सेकेंड डेकेड, राइट? सेकेंड कीवर्ड क्या होगा हमारा? प्रोग्रेसिव स्वेलिंग ऑफ लोअर एंड ऑफ फीमर. सो साइट कौन सी अफेक्टेड है? डिस्टल या लोअर एंड ऑफ फीमर अफेक्टेड है. ओके, ये इंपॉर्टेंट है, डिस्टल एंड ऑफ फीमर. नेक्स्ट, एक्सरे फाइंडिंग में क्या दिख रहा है, लेट्स सी. एक्सरे फाइंडिंग में क्या दिख रहा है यहाँ पे, ओवर हियर you can see this ray like appearance. क्या है ये, what is this ray like appearance? This is due to a periosteal reaction, right? This is due to a periosteal reaction. What is this ray like appearance known as? And what is the probable diagnosis? CT scan chest also reveals osteoblastic metastasis. Okay, so what is this condition most likely? Option A osteosarcoma, option B Ewing sarcoma, option C adamantinoma and option D giant cell tumor. Now let's rule out one by one. एक तो हमने साइट पता कर ली. सबसे पहले क्या था, डिस्टल एंड ऑफ फीमर था, राइट? डिस्टल एंड ऑफ फीमर मतलब यहाँ पे कहाँ दिख रहा है, इट इज यूजुअली एट द मेटाफाइसिस. गाइस ये देख लो कहाँ पे दिख रहा है ये तुम्हें, मेटाफाइसिस पे दिख रहा है ना, नेक पे. इट इज नॉट सीन इन द शैफ्ट, इट इज नॉट सीन इन द डायाफाइसिस. सो जो डायाफाइजियल ट्यूमर्स है वो वैसे भी रूल आउट कर सकते हो, दैट इज एविंग सार्कोमा एंड एडामेंटिनोमा. आई हैव ऑलरेडी टोल्ड यू बोथ ऑफ दीज आर योर डायाफाइजियल ट्यूमर्स. एविंग सार्कोमा और एक तरह से रूल आउट कर सकते हो, दिस इज यूजुअली सेकेंड डेकेड, राइट? एविंग सार्कोमा इज मच मोर कॉमन इन द फर्स्ट डेकेड, राइट? एंड थर्ड इज योर जायंट सेल ट्यूमर. जायंट सेल ट्यूमर में यूजुअली क्या होता है, यस इन्वॉल्वमेंट इज एट द मेटाफाइसिस, बराबर. सो साइड से तो हम नहीं पता लगा सकते. Second decade, is giant cell tumor common in second decade? No, it is usually common in the third decade, right? Around 30 years or after 30 years of age. And at the metaphysis, what we can see, we can usually see a soap bubble appearance. ये question आया था FMG में, right? जून में अभी. So what is the answer over here? No, it is not GCT, guys. GCT में soap bubble दिखता है, यहाँ soap bubble दिख रहा है क्या? This is your sun ray. अभी पता चलेगा. This is your sun ray or sunburst appearance which is seen. This is your sun ray or sunburst appearance. And which is the condition in which we can see sun ray or sunburst appearance? It is your option A, that is osteosarcoma. Now let's discuss few important points about osteosarcoma, guys. First of all, important one, osteosarcoma का most common age group कौन सा है? The most common age group it affects is your second decade, 11 to 20 years, right? So second decade में दिखता है more commonly, right? Important point क्या है? It is a radiation induced tumor. If there is a history of radiation exposure 10 to 15 years ago, that can be a predisposing factor to osteosarcoma. It is a radiation induced tumor. Next one, which is the most common site? We have already seen the most common site. It is a metaphyseal tumor. So the most common site is your metaphysis. And which is the most common bone? Again it is your femur. So याद रखना femur is very common. Okay, फीमर पे ट्यूमर भी कॉमन है, फ्रैक्चर्स भी कॉमन है, बहुत सारी चीज़ें कॉमन होती है. सो विच इज़ द मोस्ट कॉमन साइट? द मोस्ट कॉमन बोन वुड बी डिस्टल एंड ऑफ फीमर. ओके, इट इज़ योर डिस्टल एंड ऑफ फीमर और योर लोअर एंड ऑफ फीमर. नाउ व्हाट वी कैन सी ऑन एन एक्सरे? एक्सरे पे क्या क्या दिखेगा? सबसे पहले एट द अर्ली स्टेजेस वी कैन सी अ पेरिओस्टियल रिएक्शन लाइक थिंग. वी कैन सी अ पेरिओस्टियल रिएक्शन लाइक थिंग. देन वी कैन सी अ Codman's triangle. Then we can see a Codman's triangle, okay, which is a wide area of activity. Codman's triangle क्या होता है actually? It is a wide area of activity. So for example, this is your metaphysis. यहाँ पे over here you can see a Codman's triangle like this. I'll show you, okay. Wide area of activity would be seen. And next, lastly क्या दिखेगा हमें? Sunburst या sun ray appearance दिखेगा, ठीक है. So these are the important X-ray findings which are seen in cases of osteosarcoma. The metastasis in cases of osteosarcoma. The most common site of metastasis in cases of osteosarcoma is what? Please remember, it is your lungs. The most common site of metastasis in cases of osteosarcoma is lungs, and usually osteosarcoma leads to osteoblastic metastasis. Usually metastasis कैसे होते हैं? Osteoclastic, bone को break करने वाले. But in cases of osteosarcoma we can find osteoblastic metastasis. Treatment क्या करेंगे हम usually? So please remember, treatment in this condition would be a surgery, okay, because this is radio resistant tumor. Chemotherapy भी mostly काम नहीं करती है, okay. In some tumors it can work, in some tumors it doesn't. Therefore surgery is a treatment option, okay. I hope now this is clear to you. So the answer over here to this question is osteosarcoma, guys. Moving further to our next question, question number 15, which states what is the most pathognomic sign of a fracture? What is the most pathognomic sign of a fracture? Options are option A tenderness, option B abnormal mobility, option C swelling, and option D crepitus. I hope now you can answer it easily, guys. I hope this can be answered easily. Which is the most pathognomic, I am asking, most pathognomic sign of fracture? मतलब ये है तो 90% ऑफ द टाइम्स फ्रैक्चर होगा ही. लाइक दिस इज व्हाट वी कॉल अ पैथोग्नोमिक साइन. सो व्हाट इज द साइन, प्लीज टेल मी. सो सी, स्वेलिंग इज वेरी नॉन स्पेसिफिक. बहुत सारी कंडीशंस में प्रेजेंट हो सकती है, ट्यूमर में भी हो सकती है, राइट. इट कैन बी प्रेजेंट इन इन्फेक्शन ऑल्सो, सेप्टिक आर्थराइटिस में भी हो सकती है, बहुत सारी कंडीशंस में. सो इट इज नॉट ऑलवेज डायग्नोस्टिक ऑफ फ्रैक्चर, राइट. क्रेपिटस इज नॉट ऑलवेज फेल्ट इन अ फ्रैक्चर. फ्रैक्चर में हमेशा क्रेपिटस मिलेगा ये जरूरी नहीं है. Tenderness, a pain like pain on touching is also seen in some of the tumors, also seen in septic arthritis, also seen in avascular necrosis. So again, tenderness is not very much like the most pathognomic. So please remember, the most pathognomic sign over here is option B, abnormal mobility. Abnormal mobility of that joint or that part is the most pathognomic sign of a fracture. And which is the most common sign? So please remember, if they ask, the most common sign of a fracture would be tenderness. Okay, बाकी कुछ हो ना हो, tenderness would be present. Okay, so the most common sign of a fracture would be tenderness, but the most pathognomic sign of a fracture would be abnormal mobility. Moving further to our question number 16, guys. Question number 16 states, a person complains of sharp pain and decreased sensations over the surface in the below given image. इस इमेज में ये जो सरफेस मार्क्ड है, इस पे ही इज कंप्लेनिंग ऑफ शार्प पेन एंड डिक्रीज्ड सेंसेशंस. दिस कंडीशन इज मोस्ट लाइकली रेफर्ड टू. ऑप्शंस आर ए स्कियाटिका, बी टार्सल टनल सिंड्रोम, सी मेराल्जिया पैरासिटिका एंड डी कंपार्टमेंट सिंड्रोम. व्हाट इज योर आंसर टू दिस क्वेश्चन? सो प्लीज रिमेंबर गाइज, विल डिस्कस वन बाय वन. सबसे पहले तो टार्सल टनल सिंड्रोम. Okay, what is tarsal tunnel syndrome? Tarsal tunnel located कहाँ होती है? Tarsal tunnel is located at the ankle joint, right? It is usually located at the ankle joint, where there is a flexor retinaculum over the tarsal bones, and in this flexor retinaculum, which nerve passes? So in this flexor retinaculum beneath this, it is your tibial nerve. So please remember, it is your tibial nerve. So in cases of tarsal tunnel syndrome, there is compression of the tibial nerve. So compression of tibial nerve can lead to tarsal tunnel syndrome. Similarly, sounding one is your carpal tunnel syndrome. Carpal tunnel syndrome occurs in your wrist, and the nerve compressed or injured in cases of carpal tunnel syndrome is your median nerve, right? Remember this, important. Next, okay, so this cannot be tarsal tunnel syndrome for sure. Yes, very good, Srini. The answer is over here is option C, melalgia parasthetica. Okay, so what happens is, in melalgia parasthetica there is compression or injury to which nerve? There is compression to the lateral cutaneous nerve of thigh. Okay, so where are we seeing this area? This area is which one? This is the lateral aspect of the thigh. Okay, so the lateral cutaneous nerve of the thigh, by the name itself we can remember, the lateral cutaneous nerve of the thigh would innervate the skin over the lateral aspect of the thigh. It would innervate the skin. यहाँ पे सप्लाई करेगी ये lateral cutaneous nerve of thigh ना, इसके ऊपर की स्किन को सप्लाई करती है. So therefore, if there is compression or injury to this lateral cutaneous nerve of thigh, there would be sharp pain in this area along with decreased sensations, right? So this condition is known as melalgia parasthetica. Sciatica, as we all know, sciatic nerve is the longest or the largest nerve in the lower limb, right? It is the longest or the largest nerve in the lower limb. That is your sciatic nerve, largest nerve होती है. Okay, it is your largest nerve. So what happens if there is injury to the sciatic nerve? First of all, there would be pain throughout the lower limb. There would be pain throughout the lower limb. And second thing क्या याद रखोगे? स्कियाटिक नर्व की एक ब्रांच होती है और कॉमन पेरोनियल नर्व. एंड अगर स्कियाटिक नर्व इंजर होगी, डेफिनेटली कॉमन पेरोनियल नर्व पैल्सी होगी, लीडिंग टू tibialis anterior muscle palsy, leading to foot drop. Okay, so sciatica is actually diagnosed with these two findings. Next is your compartment syndrome, for which we have already discussed. Okay, one more question is there for compartment syndrome, where we will discuss it in details. Question number 17. A patient sustained an injury and was complaining of pain in the right upper limb. The patient was asked to flex the wrist on which no deviation was seen. The patient was asked to perform the following test, which is used to check the function of. Okay, so please remember क्या हुआ यहाँ पे कि राइट अपर लिम्ब में पेन है पेशेंट को, देयर वाज एन इंजरी. अभी पेशेंट को हमने क्या पूछा, we have asked the patient to flex the wrist. Okay, we have asked the patient to flex the wrist and there is no deviation seen. Okay, no ulnar, no radial deviation is not seen in this condition. So the patient was asked to perform the following test, which is used to check the function of which muscle or which of the structure. Okay, and the options are palmar interossei, dorsal interossei, flexor pollicis longus and adductor pollicis longus. Anybody, what is this test known as? So let's discuss, guys, first of all. Okay, which is this test? So first of all, the condition over here is actually they are talking about an ulnar nerve injury. So याद रखना, ulnar nerve is very much important. Ulnar nerve is also known as musician's nerve because it innervates the intrinsic muscles of the hand and controls the fine movements of the hand, right? Therefore it is known as musician's nerve. So ulnar nerve का क्या है? If there is an injury to the ulnar nerve above the elbow यहाँ पे almost, okay, ulnar nerve passes behind the medial epicondyle, right? Then it comes into the cubital tunnel and then it comes anterior to the forearm. So if the injury is above the elbow, then the deformity seen would be a partial claw hand. See, okay, partial. The medial 1.5 digits, okay, जो दिखते हैं उसमें क्या होगा? The medial 2 digits would, यहाँ पे क्या हो रहा है? यहाँ पे extension at the metacarpophalangeal joints and flexion at the interphalangeal joints दिख रहा है. Okay, this is what is a claw hand and only 2 fingers are seen in this position, therefore it is known as a partial claw hand. Complete claw hand मैंने कब बोला? Median plus ulnar nerve injuries में दिखता है, right? So this is a partial claw hand along with a flat hypothenar eminence, right? यहाँ पे जो मसल वेस्टिंग दिख रही है बिकॉज अल्नार नर्व तो इंजर्ड हो गई, सो यहाँ पे पैरालिसिस हो जाता है इस हाइपोथेनार मसल का. नेक्स्ट, ये तो मोटार कंपोनेंट हो गया. व्हाट इज द सेंसरी कंपोनेंट विच वुड बी अफेक्टेड? सो सेंसरी, यूजुअली अल्नार नर्व सप्लाई इनर्वेट्स व्हाट? इट इनर्वेट्स द स्किन ओवर द medial 1.5 digits, also from the palmar aspect and also from the dorsal aspect. So palmar aspect में भी और dorsal aspect में भी ये medial 1.5 digit जो होते हैं, okay, your ring finger का half and your little finger, they are innervated by your ulnar nerve. Okay, so that would cause a sensory loss. If there is compression at the cubital tunnel and the ulnar nerve is injured at that level over here, that is known as your cubital tunnel syndrome. Here there would be compression of the ulnar nerve as it passes behind the elbow, behind the medial epicondyle. Question came in December 2020 session. Area of humerus was marked, okay, medial epicondyle was marked, and it was asked which is the most common nerve which would be injured in the fracture of this marked area, and that was your ulnar nerve. Okay, in cases of cubital tunnel syndrome, we can see intrinsic muscle wasting of the hand along with this Wartenberg sign when the little finger is not able to adduct or join the other fingers. Okay, next one, the test which are seen usually in cases of ulnar nerve injury. What is this? This is your Igawa test, when actually hand is resting on the table and we ask the patient to lift the finger and move it sideways, और patient ये नहीं कर पाता. The patient cannot move the finger sideways. Why the patient cannot move the finger sideways? Please remember, guys, as we all know, ulnar nerve innervates what? Ulnar nerve innervates palmar as well as dorsal interossei, right? It innervates palmar as well as dorsal interossei, right? As this palmar and dorsal interossei, इनका function क्या होता है? Palmar interossei causes adduction, that is pad is the mnemonic, बराबर? Palmar interossei causes adduction, ये काम होता है इनका. And dorsal interossei causes what? Dorsal interossei causes abduction, dab. So pad and dab is the mnemonic, right? So palmar interossei, adduction. Dorsal interossei, abduction. Okay? Palmar interossei, adduction. Dorsal interossei, abduction. Right? So this is what is the function. So agar ulnar nerve injured hai, both of these interossei would not work and therefore the patient cannot either abduct or adduct the finger. This is your Igawa's test. Next is your Froment's test or Froment's sign, which is also known as your book test or your card test. इसमें क्या होता है? The examiner or the doctor gives a card to the patient to hold, okay, and the patient is usually asked to hold the card between your index and the thumb, index finger and the thumb. Normal patient कैसे hold करेगा? इस तरह से, right? The patient will use his adduction, okay, he will adduct his thumb and then hold. But what happens usually in cases of ulnar nerve injury, this adductor pollicis muscle is injured. Okay, what happens? Adductor pollicis muscle is paralyzed. As we all know, all the muscles of the thumb are innervated by the median nerve except one muscle, that is your adductor pollicis, which is innervated by the ulnar nerve. I hope this is clear. All muscles of the thumb are innervated by the median nerve except one, that is adductor pollicis, that is innervated by your ulnar nerve. इसीलिए क्या होता है? Adduction काम करता है in median nerve injuries. Okay, adduction काम करता है in median nerve injuries. So याद रखना. So what happens in this condition? As the adductor pollicis muscle is not working due to ulnar nerve injury, the patient would try to hold the card by flexing the thumb. Flexor pollicis longus काम करेगी इसकी अभी. Okay, flexor pollicis longus तो किससे इनर्वेट होती है? मैंने क्या बोला? बाकी सब मसल्स मीडियन नर्व से. So मीडियन नर्व इसकी ठीक है. Therefore flexor pollicis muscle flexor pollicis longus muscle would take over the function, and the patient will hold the card like this or the book like this, and this is known as your Froment test positive, seen in cases of ulnar nerve injury. Okay, this is what is seen in our condition also. This is a normal condition, and here the patient could not hold it properly, therefore the patient is flexing the thumb, right? So what is the injury? The patient was asked to perform the following test, which is used to check the function of. Now this is used to check the function of which muscle? As we all know, for palmar and dorsal interosseous, we perform the Igawa's test, right? We perform the Igawa's test. For flexor pollicis longus and for adductor pollicis longus. Now tell me, flexor pollicis longus is injured in median nerve injury, so it is already ruled out. So please remember, this test, known as Froment's test or Froment's sign or book and card test, is usually used to check the function of option D, adductor pollicis longus muscle. Adductor pollicis longus muscle, right? As in this case it is injured, therefore the patient cannot hold it properly. Adduction से नहीं hold कर पाता वो. Moving further to our next question, guys. Question number 18. In osteoporosis, the serum calcium and ALP levels are. Important question, and we tend to confuse it all the time. Okay. In osteoporosis, serum calcium and ALP levels are high, low, normal, none of the above. Just tell me, in cases of osteoporosis, what happens? As we all know, guys, bone, as we all know, it is made up of 10% of bone cells, then 25% that is organic matter, that is proteins, and 65% of inorganic matter, those are your minerals, right? If the cells are not working properly, if there is activation of your osteoblast cells, okay, osteoblast agar activate ho jate, that can lead to Paget's disease, or it can also lead to osteopetrosis. What do we mean by osteopetrosis? It is also known as marble bone disease. So if there is overactivation of osteoblast cells, then it can lead to Paget's disease and osteopetrosis, also known as marble bone disease. Agar protein defective hai, as we all know, if the protein, which is the protein seen in bone, it is your type 1 collagen. If type 1 collagen is defective, hereditary condition kaun si hai? Osteogenesis imperfecta, blue sclera, sensory neural hearing loss, and recurrent bony fractures, triad of osteogenesis. And next condition, if the hydroxylation of collagen is not occurring properly, bleeding gums dikhenge, petechial rashes dikhenge, deficiency of some vitamin would be seen. So please remember, it is your scurvy, deficiency of vitamin C. It is also protein defect. Okay, it is also protein defect. Next, mineral deficiency. Okay, agar mineral deficiency ho jati hai, that can lead to decreased mineralization of the bone. Okay, decreased mineralization of the bone ho jayega, and decreased mineralization of bone is seen usually in conditions like rickets, and it is usually seen in conditions like rickets and what? Please remember, osteomalacia. So rickets is usually seen in cases of children, osteomalacia in adults, right? So these are the things. So what happens in osteoporosis then? So osteoporosis mein yaad rakhna, it is a proportionate decrease in all components of cells. It is proportionate decrease in all components of the cells. ठीक है, cells भी कम होंगे, proteins भी कम होंगे, minerals भी कम होंगे. So it is a proportionate decrease in all components of cell. Therefore, very good, Srini. The answer over here is option C, normal. In cases of osteoporosis, the serum calcium and alkaline phosphatase levels would remain normal. Okay. So osteoporosis is usually seen in which age group? It is usually seen in elderly age group. Okay. Elderly, sex कौन सा, male या female? It is more common in females. So please remember, osteoporosis is more common in elderly menopausal females, जिनका menopause हो चुका है. Okay, so please remember this. Fragility fracture. As osteoporosis में क्या होता है? Proportionate decrease in all components would be there, which will lead to decreased mineral density. Okay, the density of the bone would be decreased, that we have already seen in the earlier image. I have told you, right? Osteoporosis circumscripta में क्या दिख रहा था? Mineral density कम हो रही थी. So the bone would get more predisposed to fracture. So these are known as your fragility fractures. Okay, fragile हो जाता है बहुत ज़्यादा bone. And the most common site for your fragility fractures are what? It is your dorsolumbar spine. Okay, it is your dorsolumbar spine. And which is the most common site in dorsolumbar spine? It is your T12 to L1 vertebra. It is your T12 to L1 vertebra. What are the features which can be seen on an X-ray? Okay, X-ray will show what? So please remember, X-ray will show usually a codfish vertebra. X-ray पे क्या दिखेगा हमें? A codfish vertebra would be seen, or we can see a ground glass opacity. We can see a ground glass opacity in the vertebral body. Investigation of choice usually क्या है? DEXA. Okay. DEXA scan is usually the investigation of choice in cases of osteoporosis, which is a metabolic bone disease. Rather, the most common metabolic bone disease is osteoporosis. So investigation of choice is DEXA. DEXA में कौन सा स्कोर असेस करते हैं हम? T स्कोर. T स्कोर नॉर्मल कितना होता है? Up to -1 it would be normal. -1 to -2.5 it would be considered osteopenia. Okay, osteopenia मतलब decreased mineral bone density. And more than -2.5 it is considered osteoporosis. So T score of more than -2.5 is considered osteoporosis. This question has been asked, and T score is assessed on which investigation? It is assessed on DEXA. And what is the treatment of choice? The treatment of choice in cases of osteoporosis is usually bisphosphonates. Okay, calcium and vitamin D supplementation should be in adequate levels, not excess. Bisphosphonates are the treatment of choice, that is alendronate, xalendronate drugs. Right, so I hope this is very much clear to you now. Moving further, question number 19. A patient was vaccinated for COVID-19 but was experiencing pain and loss of sensation over the area. On examination, he was not able to abduct the arm. Which is the most likely injured area in this condition? And the options are: option A, rotator cuff muscle; option B, anterior humeral circumflex artery; option C, deltoid muscle; option D, humeral circumflex nerve. This is very easy question, guys, asked in recent INR CET question examination. So बहुत easy है guys. See, patient क्या है? Vaccinate हुआ है COVID-19 के लिए, right? But was experiencing pain and loss of sensation over the area. COVID-19 vaccine is usually given intramuscular, right? ओवर कहाँ पे दी जाती है? ओवर द डेल्टॉइड, अपर एस्पेक्ट ऑफ द आर्म, डेल्टॉइड पे दी जाती है. इसी से आंसर पता चल गया यूजुअली आपको, बट लेट्स सी फर्दर. ही इज एक्सपीरियंसिंग पेन एंड लॉस ऑफ सेंसेशन ओवर दिस एरिया. सो पेन तो मोटर कंपोनेंट है. लॉस ऑफ सेंसेशन ओवर दिस एरिया इज नोन व्हाट? लॉस ऑफ सेंसेशन ओवर दिस अपर एस्पेक्ट ऑफ द आर्म. यहाँ पे अगर लॉस ऑफ सेंसेशन हो जाए, व्हाट इट इज नोन एज? इट इज नोन एज सम साइन. इट इज नोन एज योर रेजिमेंटल बैज साइन. ओके, यूजुअली आर्मी में जो रेजिमेंट होता है उनका बैज यहाँ पे पहना जाता है. ओके, सो यहाँ पे अगर लॉस ऑफ सेंसेशन हो जाता है, देन दिस वुड बी नोन एज योर रेजिमेंटल बैज साइन, राइट? रेजिमेंटल बैज साइन. एंड रेजिमेंटल बैज साइन अलॉन्ग विथ दिस एग्जामिनेशन पे क्या दिख रहा है हमें? नॉट एबल टू अबडक्ट द आर्म. अबडक्शन मतलब टेक आर्म अवे फ्रॉम द बॉडी. ये किसका ऑलमोस्ट फंक्शन होता है? It is the function of supraspinatus from 0 to 15 degree, and from 15 to 90 degree it is the function of deltoid muscle, right? So please remember, deltoid का function होता है usually. So यहाँ पे क्या हुआ है? Injury to the deltoid muscle. Option C is the answer. Very easy. But मैं क्या बोलना चाहता हूँ? Please remember, in cases of your sharp injuries, needle injuries, okay, sharp injuries or needle injuries, or in cases of trauma, or in cases of shoulder dislocation. Okay, so trauma, sharp injuries or shoulder dislocation at this site, at the upper aspect of the arm near your shoulder, the most common nerve affected is what? The most common nerve injured would be your axillary nerve. याद रखना, the most common nerve injured would be your axillary nerve. याद रखना, ये important है. Okay, axillary nerve is the most common nerve injured, right? So axillary nerve innervates which muscle? It innervates teres minor muscle एंड डेल्टॉइड मसल. ओके, ये उसका मोटर कंपोनेंट हो गया, टीरियस माइनर मसल एंड डेल्टॉइड मसल. सो व्हेन एक्सिलरी नर्व का इंजरी हो जाएगा, देयर वुड बी पैल्सी ऑफ टीरियस माइनर एंड डेल्टॉइड मसल, राइट. एंड एज डेल्टॉइड मसल इज पैरालाइज्ड, देयरफॉर देयर वुड बी लॉस ऑफ abduction from 15 to 90 degrees, right? Important. And along with that, it innervates the skin over the lateral aspect of the upper arm. So मतलब यहाँ पे loss of sensation भी हो जाएगा जब axillary nerve injury है. So this is known as your regimental bath sign. Axillary nerve injury can also lead to regimental bath sign. I hope this is very much clear to you now, right? So yeah, this is with this. Now the last question, guys. This is very interesting question. Just be attentive for the last question for today's discussion. Then we'll end the session. Question number 20. A patient sustained a leg injury and was brought to the emergency. A X-ray revealed closed, displaced mid-shaft fracture of left tibia. The patient was given a splint and admitted for intramedullary kneeling the next day. But in middle of the night, the patient complains of excruciating pain, not relieved on analgesics. You perform passive dorsiflexion. Dorsiflexion क्या होता है? Usually this is your leg, okay? So this is your dorsiflexion. जब for example this is your leg, guys, okay? सब ऐसे मोड़ोगे उसको, that is known as your dorsiflexion. So that is known as passive, मतलब if you are performing the dorsiflexion, it will be known as passive dorsiflexion, okay? So you perform passive dorsiflexion and patient complains of pain exacerbation, मतलब पेन बढ़ जाता है. Most likely diagnosis. X-ray किसका दिया है? X-ray दिया हुआ है. We can see fracture of the left shaft of the tibia. Okay, fracture of the left tibial shaft. Okay, fracture of the left tibial shaft can be seen. अबे keywords I have already marked. Let's see. सबसे पहले क्या है कि there is a closed fracture. Okay, it is displaced. Okay, कौन सा फ्रैक्चर है? मिड शाफ्ट फ्रैक्चर ऑफ टीबिया है. पेशेंट को स्प्लिंट दिया था एंड ही वाज एडमिटेड फॉर इंट्रामेडुलर नीलिंग सर्जरी फॉर द नेक्स्ट डे. बट रात में ही पेशेंट कंप्लेन करने लगा कि देयर इज एक्सक्रूशिएटिंग पेन एंड विच इज नॉट इवन रिलीव्ड ऑन एनाल्जेसिक्स. यू परफॉर्म पैसिव डॉर्सीफ्लेक्शन जब करते हो, देयर इज एक्सेसिव पेन. सो मोस्ट लाइकली डायग्नोसिस ऑप्शंस आर क्रस सिंड्रोम, डीप वेनस थ्रोम्बोसिस, वास्कुलर नेक्रोसिस, कंपार्टमेंट सिंड्रोम. Your answer, guys, to this question. We have studied the complications. Now it should be easier for you, right? Now it should be easier for you. So first of all, let's rule out one by one. Crush syndrome में क्या होता है? There is traumatic rhabdomyolysis, I have told you, right? So there is destruction of your skeletal muscle, and skeletal muscle destruction would lead to what? Release of myoglobin into the circulation, and as myoglobin is released into the circulation, that would go to the kidneys and damage your glomerulus, leading to what? Acute kidney injury, acute tubular necrosis cause करेगा, and that can lead to AKI, right? And usually AKI patient कैसे present करेगा? With decreased urine output or delirium, disorientation, or loin or lumbar pain, right? So this is usually ruled out. This is not seen in our case. Second is deep venous thrombosis. Very good. This is a very close differential diagnosis. Okay, so deep venous thrombosis I would like to explain you guys. DVT में क्या होता है? Usually there is venous stasis, जिसकी वजह से थ्रोम्बस बन जाता है. But most important point मैंने जो तुम्हें बताया था, क्या बताया था? DVT is usually due to history of prolonged immobilization. कब होता है DVT? ड्यू टू हिस्ट्री ऑफ प्रोलॉन्ग्ड इमोबिलाइजेशन. व्हेन द पेशेंट इज ऑन बेड रेस्ट फॉर लॉन्ग टाइम, फॉर मंथ्स एंड मंथ्स टुगेदर, राइट? इन दोज केसेस यूजुअली DVT वुड बी सीन, राइट? एक पॉइंट से तुम्हें DVT लगा होगा एंड आई एम वेरी ग्लैड दैट एटलीस्ट यू आर close to the diagnosis. So you perform passive dorsiflexion and patient complains of pain exacerbation, right? DVT में भी एक साइन होती है जो ऐसे हम एलिसिट करते हैं. When we perform passive dorsiflexion, patient experiences pain in the calf. Okay, patient experiences pain in the calf. That is known as your Homan's sign. Okay, so Homan's sign is seen. And when we press the calf in DVT, that also leads to pain. That is known as your Moses sign. So these are the two important signs seen in cases of DVT, right? But याद रखना, DVT is due to history of prolonged immobilization. यहाँ पे तो मैंने क्या बोला? Patient has been he sustained an injury today and he has been admitted for the surgery tomorrow itself. So इतनी short history में DVT होगा क्या? नहीं होगा, right? DVT cannot be seen and DVT pain is usually relieved on analgesics, right? Important thing. Now What is the next one? Avascular necrosis. Avascular necrosis is also a late complication of a fracture, or avascular necrosis is not common at this site, right? It is usually common where the blood supply is not sufficient, and blood supply at the shaft, I have already told you, it is very like there is a huge massive blood supply which is seen, because also if the blood supply is cut off, collaterals can be developed, therefore avascular necrosis के chances बहुत कम हो जाते हैं. The last one is your compartment syndrome. Very good. The answer over here is option D, compartment syndrome. Let's see how. I've told you what happens in compartment syndrome. There is increased pressure or rise in pressure in this osteofacial compartment. For example, this is your fascia and this is your bone. Okay, between these are your muscles. So there is rise in pressure in this osteofacial compartment. अगर यहाँ पे hematoma बन जाता है, और if there is muscle edema in this region, or we have applied a very tight plaster of Paris, so what happens, there would be rise of pressure in this compartment, which can lead to compression of blood vessels and nerves in this region, and as these nerves are compressed, that can lead to excessive pain, and this excessive pain would not even be relieved by analgesics. And when we perform a passive dorsiflexion, there is stretch, and that can lead to this pain exacerbation, right? So I hope this is clear to you now. And if we perform palpation at the site, you can find tense compartments. Okay, tense compartments can be seen, right? I hope now this is very much clear to you, and this session has helped you. And let's discuss the other 20 questions in the next upcoming session. And I'm glad that you have been interactive till the end of the session. Thank you so much. Let's see you in the next session of Sparks with orthopedics discussion session part 2. Thank you so much, guys.